So if I, great.
Okay, so we'll just start letting people in here. Welcome everyone as you come in. Feel free to let us know where you're Zooming or calling in from and your role in long-term care. Just let everyone come in here and then we'll get started. Hi, Julie. Welcome. Well, welcome everyone. We'll just give it a couple more minutes here as people join and then we'll get going. So feel free to pop in the chat and let us know which long-term care home you work at, where you're Zooming in from.
Yes, good evening, everyone. David Clinton Baker is my name. I'm from Victoria, work at Veterans Memorial Lodge and at Mount St. Mary's downtown.
Welcome, David. Okay, well, I'll just do a little bit of a housekeeping first. So welcome to our Victoria South Island LTCI Learning Series event. I'm Jessica, the Vic South Island LTCI Program Manager. So I'd like to take a moment to welcome you to our Learning Series event this evening with Dr. Christine Jones. It was with great respect and appreciation that I'm speaking to you on this very gray and misty day from the traditional and ancestral territories of the Sauk Nation, where I'm very lucky to work and live. So just a couple of housekeeping items. Please keep yourself muted during the event unless you'd like to ask a question. This is a CME event. A certificate will be emailed to you in the coming days by a member of our team. Please take a moment to complete our evaluation form at the end of the event. Your feedback is very important to us. This event will also be recorded and placed on our website. So please feel free to refer colleagues there who weren't able to attend today. If you do have any questions throughout the evening, please feel free to use the chat or unmute yourself and ask away. We really like these events to be as interactive as possible. And then there should also be plenty of time left at the end as well for discussion. So last but not least, I'd like to introduce our presenter for this evening, Dr. Christine Jones. Dr. Jones works at Island Health Palliative and End of Life Program, providing an additional layer of support to patients residing at home and in long-term care facilities. She is a master facilitator in serious illness communication. Dr. Jones worked with Dr. Leah McDonald on the Quality Improvement Project, Bring a Palliative Approach to Long-Term Care in 2019, which she hopes one day to see spread into our local facilities. Dr. Jones is married to Todd, mother to 4 adult children, and friend to 2 very busy dogs and 1 cat. We are very lucky to have her speak to us today. So without further ado, please welcome Dr. Jones.
Thanks so much, Jessica, and thanks for inviting me to come and be a part of this. I have realized over the years that communication is kind of what, everybody gets excited about a different part of clinical practice. And communication is that for me, not only as a way of gathering information to make sure that patients and families receive the care most aligned with their goals of care, and that they move towards authentic dying for what is right for them, not what is a good death by how I define it, but by how they and the people around them define it. But also it's a therapeutic bedside strategy where patients can feel seen and feel heard. And it can go a long way towards moving them to a place of understanding and acceptance, sometimes, not always. So I'm just so happy to talk about communication. I'm going to try and forward these slides, but they don't seem to be going. Maybe I need to do this. There we go. Okay, I have nothing to disclose. Nobody's paying me for anything these days. And no, nothing to disclose. And it looks like unfortunately, I mustn't have saved my land acknowledgement. And unfortunately, I had this beautiful picture of Mystic Vale. I was out for a walk with just one of my 2 dogs yesterday, and it was a very blustery day. And I looked up because the dog looked up, and there was noise of the branches moving back and forth and back and forth, and there was a little bit of sun that was glinting through the trees. And I had this moment of feeling so profoundly grateful to be able to walk on the lands, play on the lands, and to be nurtured in health, mental health, as well as physical health on the lands. And so I unfortunately, it's not written, and I want to get it right. The Lekwang peoples. And the Esquimalt and Songhees First Nations people. So I am incredibly grateful for their stewardship of the land and acknowledge that their historical relationship is still ongoing in definition and involvement. So the learning outcomes for this session will be to apply a framework for difficult conversations. The best way to learn conversation and clinical skills is to actually do it. And this venue isn't the easiest venue within which to do it. So we'll talk about frameworks that I hope you can then apply, watch a couple of videos, and then make sure that you've got lots of resources that you can access after this session. And I hope that over time, I just got this new job as medical director of Victoria Hospice, and with my passion for communication, I hope that over time we'll be able to offer sessions where people can come and practice and learn skills in communication beyond the serious illness conversation. And then really to think about, I was a part of that Jessica mentioned at the beginning, the palliative approach in long-term care. And much of that project was how to bring the language and end of life and the culture shift, but also the structure in which to support these conversations, and then taking that knowledge and relationship that you develop with the co-develop with the patient and those around them to bring in a systematized way to your teams, and then make sure those goals of care are appropriately valued and acted upon. So through this little presentation, I'm going to go through 4 patients, and the first one is George. Just not going to spend a lot of time in the details. 74-year-old man with moderate dementia. He's admitted directly from home after several years of his daughter caring for him. And while he's needing much more support at the home, making it difficult for his daughter to continue because she's getting older and developing her own health problems, he is in the stable phase of his illness. And I wonder if you guys can just throw into the chat, what kind of challenging conversations do you think are going to come up for this guy as we begin to get to know him in the facility? I know sometimes it's hard to put stuff out there in the chat, but I'd sure appreciate it so we can have just a wee bit of interaction. Most discussion, understand what is, oh, I love that, Arthur. You put what is important to you. That is such an important question. I also like to ask, what do we in the team need to know about you to take the very best care of you? It's called the dignity question. And that's something I use, maybe not every day, but most days. What's been challenged about why he can't be cared for home, and Kim, I like the way, so Sherry is talking about understanding a little bit more about his current status and what's so difficult. And then Kim mentions providing information about what might lie ahead, which is really the crux of these goals of care conversations. And now we're going to move on to Lenny, who's been at the facility for 6 years, but now his multiple medical conditions, particularly his renal failure, have caught up with him, and he's had this gradual loss of function. His palliative performance scale is now 20%, and he is in his active dying phase. And maybe just throw in the chat, what do you think might be different or unique or challenging about conversations at this stage? So Julie says, getting to know the family, absolutely, and the understanding of the stages of dementia for George. What about for Lenny? What do we know about Lenny and about his quality? What brings him quality? Thank you. What brings him comfort? Who would he like to have with him? I can tell you I'd be getting a little bit worried about the food and fluids conversation at this point as he's beginning to lose his swallow. Thank you, David. Yes. How is he going to feel at this stage of his renal failure? And how do you language that for the patients and family? Monitoring his pain, spiritual support. I love all this holistic stuff. His purpose of life, yes, I saw this great slide by Dr. Eduardo Barrera a few weeks ago on Instagram, because of course I follow him. And he had this really wonderful graphic of showing that the pain and the shortness of breath and the loss of function and the falls, all of that was so immediate and seems to be what pulls us in as a healthcare team. But really, it's our job to make all those physical things feel less immediate, so it can make way for the really important stuff like the spiritual care support, the purpose in life, what gives it meaning, and allowing that life to be seen in the context of not just this end of life part where there might be suffering, and we try and minimize the suffering, but in the context of this life with all of its bumps, but hopefully largely well-lived. So thank you for that. And then we have Patrick, has got advanced COPD. He's in the hospital. He's got a PPS of 40%. So he's a bit unsteady on his feet using his walker. And his goals of care were to go to the hospital to have, when he gets these exacerbations of the COPD. And previously he hadn't been on home oxygen, but now he is. And so then what are our conversations going to be? I think for him, what I would be thinking about, what about the next time? What are we going to do? Because probably he is going to have the next time. And really, I'd be thinking about what is his understanding of where he's at in the illness now. So I'd be thinking about those. Oh, there's my land one. It ended up there somehow out of order, but it can be there to remind us. And for me, it's the healing of the land. What does he think about us keeping him at the facility? Because there are effective things we can do without acute transfer. Yes. So what can be done in the facility to meet his goals of care, whatever they are? And then Michelle, and this is our last patient. So she's clinically frail and in the deteriorating phase of her illness. And so there will be conversations that are unique to this phase of her illness, and to Michelle as well. And so if I could ask you to pop your thoughts into the chat, and then I'm going to go into a much more of a didactic phase of the presentation. And why are these conversations so difficult in long-term care homes? And you can just pop one word, two word, a short phrase into the chat, and that would be very helpful. And then I'm going to review some research where these wonderful researchers actually did some qualitative research on care facility staff, and we'll look at some of their quotes. Emotional versus concrete. So these conversations can be very emotional, and sometimes that's hard for patients to understand information. But Kim, I wonder if that means does this person experience emotion or do they have preference for more concrete information? Uncertainty, yes, absolutely. Feeling a loss of control for the patients and families, and also as ourselves as part of the caregiving staff. And David says, because I most often don't know the backstory of the resident and their family. Yes, and so that is one of those skills with communication, is how do you very quickly enter into a space with a patient who may or may not have people around them, and understand who they are in the context of their illness and what's right for them at this moment of their illness, at this time, potentially as they're declining. Fear, unknown responses from families. Yes, often there's different perspectives of families. And Carolyn, I'm really interested that you put this attachments to residents and families. My girlfriend just had an experience of supporting her mom to die in a long-term care facility, and she, in her experience of it, was that there was resistance to the palliative approach. And she thought because the facility staff were so attached to her mom, and it was hard for them to begin to withdraw what felt like active treatments. And I think there was a problem with communication that Allison, I shouldn't have said her name, but Allison, in her sadness, really struggled to communicate and getting out of her emotion brain into her concrete brain. And comfort care goals and decline, and so a discordance between what the family wants, what the patient may want, if we can even hear what the patient wants, and what really are the options for care, pain management, people who's to come, end of life, and education. So thank you for all of those thoughts. Probably I don't really need to go through the next slides, as often happens. And this is a great reference that I've actually included on the very last slide, and it was published in 2023, and they interviewed a number of care homes, I think 98 staff in all, and they spoke to the different challenges with goals of care conversations. And then in the later slides, I want to show you what they thought needed to be done to support goals of care conversations in facilities. So there was a recognition by the staff that the residents often came to the facilities without a great understanding of their illness, that those conversations that should have happened before they even arrived hadn't happened, or if they had happened, there was not a great deal of a persistent understanding. So there was a block there. And that because these patients are new to you, and very often when patients come into residential care facilities, of course, they get new providers. Maybe when the family before was looking after their personal care, and now there's strangers that they're getting to know. And they have sometimes a new physician who doesn't follow them into the facility. This was very profoundly heard in the interviews, that the concern that the residents' voice can be lost. And that is due to cognitive capacity, but also disempowerment. And I think you can think of many kind of isms that might be the response for that. There may be racism, there may be ageism, there may be patients may have disability, that they can't hear properly or can't speak properly. And oh my goodness, Sherry says sometimes patients are lied to by family just going in for some tests, and not an honest conversation, but a change in home living. That sounds devastating for everybody involved. Divergent family perspectives we talked about, and that our healthcare system very much focuses on the need for medical orders for scope of treatment. And sometimes those are equated, but of course they're very different. And that the most status is really just the cherry on top of a really good goals of care conversation. So the goals of care drive the most, not the most driving the goals of care. And many patients are isolated. That was another thing that came up. And then, and I've spelled, oh no, I did spell hierarchical, maybe not. So staff comfort with discussions. There was an acknowledgement of the significant hierarchical nature of facilities, and a questioning about whether these conversations or whether being involved, opening the discussion, responding to the little pearls that get dropped by the patient about talking about this is very difficult. I feel very sad. What's going to happen to me? Is this in my scope? I don't feel skilled enough. I don't have the education. I might cause harm. There may be cultural differences, uncertainty about who you should talk to, how you should talk about it for the patient in question. And then many systems issues where these conversations are happening in the moment with the recreational therapist or with the nutritionist. But then we write our notes, but notes may be siloed or not really attended to. Those goals of care don't filter to the top of the chart because they really should be what guides all of our care is those goals of care and how the patient wishes to be treated and how they want to live their day-to-day. Lack of administrative supports to support documentation. Recently at the hospital, and some of your facilities may have power chart or access to power chart. There's an ACP section where most my conversation about goals of care goes there immediately after I have the conversation to capture it, so that their wishes around how long they want to live, if there's an event they want to live to, if who's most important to them, what is most important to them, where their preferred place of death is, et cetera, goes. And it always stays at the front of the chart so that my colleagues can see it. And then, of course, lack of time, of fear that going into these conversations, you will be drawn in and they'll be emotional and it'll be hard and you're not going to be able to leave and you've got a whole bunch of things to do on your list for the rest of the day. So I don't think this probably doesn't sound, it probably makes sense to you. I'm very grateful for the people to have done this research because it just further highlights the need for systems change, for education change, cultural change within the facility to bring that palliative lens intentionally to the facility, but also there were some recommendations made on how we can address some of these staff perceptions. So what I'm going to present here is actually some of their own words as reflected in the study. And this is going to go, doesn't seem to be go, okay. It's very important. So this is from a nurse. It's very important to be able to say your wishes while you're able to. You get diagnosed with dementia. Somebody should discuss the trajectory of the disease, what the next steps are, and what you need to look forward to. I mean, you have dementia. That's the end of the discussion. It really has to be done long before today anyway, because the residents are coming in much sicker, much more deteriorated than they used to. So they took this kind of theme and they identified that the right time is when the person has capacity, but not only cognitive capacity, but also emotional capacity, when they're ready and able to receive the gentle truth telling. And then from a physician. So once the person is at that stage and we've done everything possible, the patient's family usually have a lot of questions and you have to be ready to be responding to those questions. And I think there was actually a question in the chat that came up about ready to respond, because often we're going to be asked the prognosis and that can really be scary. And we will make some time to talk about that. The most important thing is to explain that we have, I guess, that and what we have done. Like, this is not just giving up, but we have made every possible way to make this easier and be pain-free. And you know, in the palliative care, that's the end goal of treatment too. And so often you hear language like, oh, they're a fighter, and then switching, just one of the strategies is just to say, they're a fighter, and can you tell me more about that? And here are some of the stories that displays the example of being they're a fighter. And then you might say something along the lines of, I suppose now we have to figure out in this new place what we're fighting for. What are we fighting for now? So you can continue to use that language, but then address maybe a different goal. And in this thematic analysis, they talked about goals of care as not just a one-time event, not just at the entry in and you tick off your boxes, but it's a process. Constantly assessing readiness, facilitating understanding, shepherding the person and the family through these constant transitions to a new place. So the conversations begin at entry, and then we just help people to understand how their illness is changing as they're moving through their, on average, 18-month length of stay, or I think that's lessening now, in long-term care facilities. And goals of care are much more than treatment decisions or about death, but it's about making their life authentic, enjoyable, and meaningful. And then another nurse said, and that's the important thing when we talk to families, is to remind them, you may not have had the discussion in the last year, but throughout throughout life, that person's life, have they ever said anything to you about, I don't know, I don't want to be kept alive by machines? Like those kinds of conversations, you have to sometimes help them recall those lives. And so those goals of care conversations can make the in the moment crisis decisions easier. And I have to think about advanced care planning and goals of care as really helping people to be prepared for the decisions that are likely to come. And they're about helping patients and families understand their illness, decisions that lie ahead. And then the last one here by a nurse, I guess the end of life, no one will know when that moment will happen. That's the uncertainty. But when the whole family has good communication and mutual understanding, it will help in the process of grieving. And so the thematic analysis was here. It should be a priority, and goals of care conversations aid in not only those in the moment crisis decision, but transitions and shepherding to the dying time and into bereavement. I do want to address Dr. Clinton Baker's question about prognosis. And I think maybe there's a different place. I think that'll be really great to talk about that. Discussions regarding declines that can and will happen after big changes arriving at the home. In the literature, they say the optimal time for that first goals of care conversation will be after they've settled in about 6 weeks. And then after hospitalization, after sentinel events like a fall, noticing less social interactions, and after illnesses. Yes, absolutely, Sherry. Those are what we call the indicators for a more intensive palliative approach. So part of that palliative approach will be the goals of care conversations, but you also might be leaning in a little bit more and looking at stepping up your symptom management assessment as well. So, and then where they came to was this, within this article was the future and interdisciplinary staff perceptions, but then aspirations to go from hierarchy to a team-based approach, an intentional team-based approach. And this is a quote from a personal support worker. So if a resident or family member were to come to me about that conversation, I would just refer her to the administrator. We would refer them to the charge nurse and they would follow up from there. And so this is the sense of, this isn't my scope. I'm not comfortable. I'm not trained. I don't know enough. Can't talk to prognosis. And therefore, and yet this can be very limiting. And there was a comment from the physician, I think it has to be like a team. The whole staff has to be a team so that everybody's input, because the personal support workers, I think we might call them healthcare aides here, are the primary caregivers. So their input with every shift needs to be here, or if they see something different in the resident, they are the people that are seeing the resident the most. And that's certainly what we found in our palliative approach to long-term care was one of the recommendations was to really engage with the support staff, the personal support workers, the recreational team, the dietitians, the volunteers, for them to be aware of those sentinel changes that might indicate a change and therefore initiate goals of care conversation, or to see the opening to talk about what's most important at this time. And so, yeah, goals, they're happening anyway, and how do we capture them? And then PSW, I do believe it should involve PSWs, because we are the ones that see the residents every day, and the ones that actually sit and talk to the residents, and the majority of the residents recognize our faces because that's who is with them. And they happen in, so really that this acknowledgement is that they happen in formally in family meetings and doctor's visits, but more often the important stuff happens during informal day-to-day conversations. And how do we respond to those? So then this is moving towards the future now. And so from hierarchical to an intentional interdisciplinary team approach. And I just have this HANDS, which I hope is coming out okay. That is the result of one of the quality improvement projects that I did with the renal folks, the dialysis unit. And this was really, some of the things that came up in this article were very much similar to what came up in our work with the folks in dialysis. Because it was difficult to find time, people didn't feel skilled, and yet it was the dialysis staff, it was the dietitian, it was the pharmacist, it was the spiritual care provider, who were all sitting with the patients most of the time, because the nurses were so absorbed in the tasks with caring for the patient. And so we came up with this idea that each person can own a part of the serious illness conversation. They can ask about the goals if the healthcare situation should worsen. What are they understanding? What would they be willing to go through for the possibility of more time? What abilities are so critical that you can't imagine life without them? Fears and worries. What are your sources of strength? How do you want your family to be involved? And of course, these conversations will be adjusted towards the long-term care facility. We're going to talk about that in a little bit. But it really was about giving permission to non-physician staff to have these conversations, to non-nursing staff to have these conversations, building trust between the team members, knowing that they were going to have these sensitive conversations, that they weren't going to do harm. And that could only happen with training to develop really good provider to patient and family communication skills, training to develop provider to provider communication skills, and strategies to identify when the resident is changing and goals of care should be revisited. What are the resources to augment the discussions? Where are the opportunities to actually practice these conversations so you can feel skilled and confident in these low risk practice scenarios, so that when the high risk in the moment conversation happens, you're ready for it. And then also, where are the opportunities for debrief? Because these conversations can be challenging, they can be emotionally laden, and we can't really expect to just sort of say, okay, off you go, we've given you this training, off you go, we have the system in place, and then yet not attend to the person at the bedside having the conversations, because they can be so very emotional. So now what I'm going to do is just revisit each one of those patients. So we have George, who's a 74-year-old with moderate dementia, admitted from home. And so how are we going to, what would the literature say would be one of the best ways to approach this? And I'm sure you guys all have processes within your facilities, and they'll all be a little bit different, but likely the same principles. But the long-term care initiative out of Ontario, as I said, recommends that there is a meeting at about the 6-week mark. And one of the things that is really, I'm noticing that many more of the long-term care physicians in our community are using is a modified serious illness conversation, where they will talk with the patient if they are capable and wanting to be involved, but certainly the family, to just use this structured conversation. And there's lots of training opportunities out there to learn this on using patient and family tested language, on assessing, understanding, knowing how much information they want about their illness, and providing a prognostic statement on what to expect from the future, and getting at goals and what makes life most important. And because there's so many other things I want to talk about, I don't want to spend a lot of time on the serious illness conversation, and I imagine you guys have seen this before. But I would just encourage, and as I said before, that we as clinicians can all own a small portion of this, or I have this conversation in its fulsome manner in about 12 to 15 minutes with most patients. And so another article that I popped in, which from a 2023, I think, a social work journal of the American Medical Director Association, is that the use of ACP workbooks. And there's lots of ACP workbooks out there. And essentially this one here, What Matters to Me, really mimics the serious illness conversation in a question that it asks, but it does it where people can have some time to reflect. They might do it with their family members, and if they actually can write down, so that may be more comfortable for them to do even before or after a conversation. They can share it with their family members. And if you guys look on Speak Up, there's ACP workbooks, and so they applied these to a series of, I think, 58 family members and patient dyads. And they were found to be acceptable and helpful to deepen goals of care conversations. So it's another resource that you can use. And then, and one of the participants here talked about helping people to understand what might lie ahead. And I really hope every single one of you guys has seen this wonderful roadmap for families when your loved one has dementia. That really takes them through what to expect as the illness progresses. We use the word dementia so often in general language that I don't think many people really understand that in of itself, it's a life within the illness that has a fairly predictable progression. And so again, it's about preparing people for what is to come. And in one of the ACP workbooks, the one on Speak Up, it has this kind of infographic in it, and you can see that the yellow ovals and circles really helps to focus the eye on the important questions. This isn't about, do you want CPR? Do you want to go to the hospital? Do you not want to go to the hospital? This is about questions that, if answered, we can figure out whether going to the hospital or not is most appropriate. We can do that shared decision-making with the patient and those around them, if there is someone around them. And so now I just wanted to show you some of the resources as part of the palliative approach that you can augment your conversation with. So I did show you the important resources from the roadmap to dementia, but this was also out of this same project, of which this article that I showed you on staff perceptions, that's part of a bigger study that includes the development of these resources. Because if patients and families don't understand what's to come with their illness, how can they possibly be expected to make decisions? And so this is why I'm spending so much time on it. So there's the palliative approach for advanced frailty and long-term care, for advanced lung disease, for advanced kidney disease, for advanced heart failure. And there's many more pages to each of these pamphlets, but you can see it talks about the trajectory, and residents show a decline in muscle mass and strength, energy, walking speed, activity levels, and on. How does lung disease progress? So you've got these acute exacerbations, and when people recover, they never come back up to their baseline. But at the time of death, sometimes it feels sudden, because every time the patient seems to recover from their acute exacerbation. But there's often this period at the end of a COPD trajectory or pulmonary fibrosis trajectory where there's a period of accelerated disability towards the dying time. And then how does advanced kidney, it looks very similar, advanced kidney disease to lung disease. and as does heart failure progress. But they all have slightly different symptoms, which are outlined in these pamphlets. So it really sets people up to not be so surprised and shocked when things happen. And so now we have Lenny at his PPS of now 20%. And I'm just going to try and show you this video on the end. Have you guys, anybody used the Ask Tell Ask before? If you can just pop a thumbs up or a yes or a no, just while I'm pulling up this video, please, into the chat. No, okay, good. I love it when it's no, but Gloria says yes. So here is just so this is from the healthcare quality improvement. And this is a structure for which you can use for any difficult conversation. And there's all kinds of these fancy communication skills courses you can take, but and acronyms you can use, and we will talk about some of them, but every single one of them uses the Ask, Tell, Ask as their foundation. Is that coming through, guys?
So Ask Tell Ask is just a simple reminder to clinicians of a way that's to increase the chances of their information or advice really landing on receptive ears. And so the way Ask Tell Ask works is the first ask, they have a couple of options, but one good option is to ask permission to give your information or advice. And that's really a way to respect the person's autonomy. And another way to do it is to ask what they already know or what they want to know, so that you're really gearing your information or advice to what they're interested in. So you have two options for that first ask. And then tell, you need to tell your message simply, 1 or 2 points in what you might think of as living room language. So really focus in on things that are personal and specific to that individual in that situation. And then the last ask, again, you have two options. You can ask what they think of the information that you gave, or you can ask a teach back question to check for understanding. So ask permission or how much they want to know, tell your information clearly and concisely, and then ask what they think of it, or ask a way to check for understanding using teach back.
Is that coming in too, guys?
So Ask Tell Ask is just a simple reminder to clinicians of a way that's to increase the chances of their information or advice really landing on receptive ears.
And can you guys now see see my slides again? Jessica, can you let me know if it's come up?
Yep, we're looking at the YouTube URL.
I'm so sorry that didn't work. So for Lenny, who's declining, so what we might do then, this is just a completely made up scenario that I acknowledge it would never in real life go quite so smoothly, but here's an example of how you might use it. So first of all, you're asking permission. Is it okay if we talk? Oh, I hadn't made Lenny up when I did this, but we'll pretend Lenny's a woman. Is it okay if we talk about the changes in your mom's eating and drinking? And then you provide some space. And then asking about understanding. What have you noticed about how things have changed for your mom in these last weeks? Do you have a sense as to why this is happening? What have the doctors told you? And is there any information that might be helpful to you? So you might imagine that they would say, yes, I want to talk about it. She's not eating enough and I'm worried that, you know, she's going to starve to death. And then you notice about how things have changed. And probably what'll come up is that she's less and less active. She's not going out she used to go out to the activities, but that's about 3 months ago. She stopped doing that, spending most of her time in her room. Sometimes there's periods of confusion. Do you have a sense as to why this is happening, to get understanding? And sometimes there's the impression that they're doing less well because they're not eating, rather than not eating because they're moving towards their dying time. And then you move to the tell part. And so I just want to preface this by saying you should always be speaking less than you're listening, because we have a tendency in healthcare to tell what's happening rather than listening, because it's the listening and the responding to the emotion that's most important. So I've noticed that she's eating less and less also. She has a dry mouth, and we've added in some artificial saliva, and we're doing regular mouth care with moistened swabs. The dentist came in and adjusted her dentures. But I also noticed that she seems to be choking a bit more often when she swallows and coughs afterwards. She turns her face away from us when we try to feed her. And then provide a little bit of space, a little bit of silence. And then, is it okay if we talk, or would you like to talk about what that means? That is a little bit of a lob forward, that this behavior or this change has a significance, and it just gets them emotionally ready for what's coming next, which could potentially be some bad news. And then you tell. And so I've highlighted in blue some of these literature supported strategies of communications. And the first thing is the use of the language, I wish, I worry, I wonder. And so the worry is something that finds its way a lot into my language. I worry this might be a sign of her illness progressing. People with dementia do lose their appetite over time, and their swallowing becomes more difficult. I've also noticed that she's sleeping a lot. I think we might be in a new place now. I even wonder if she might be coming soon to her dying time. And then you make space for silence and respond to emotion. And there is an acronym called NURSE, which NURSE, which you may or may not have seen. And I haven't included in this, but I can certainly provide the link where you name the emotion, but you never name the emotion. If someone starts crying, you wouldn't say you seem devastated. You would say things like you seem upset. Or if someone gets angry, you don't say, wow, you're sure angry. You say, I can see, it feels to me like you're upset. So you always dial down the emotion a little bit. And then you try to understand the emotion by saying something like, can you tell me a little bit more about how you're feeling, or what's in your heart, or was this a surprise to you? Can you tell me a bit more? And then you respond to that emotion. You support the emotion and can say, I can't imagine how difficult this is for you. And then you begin to empathize with that phrase and finding a way forward. And then you can move into the ask. Knowing the illness is progressing, and time might be short, what is most important? Tell me more about that. So you've asked, I wish, and I'm going to have to move this because I can't see the words here. I wish things were different. I wish that continuing to feed her would help her get better, but I worry that her illness is progressing, and that if we continue to feed her, she might choke or accidentally breathe food or fluid into her lungs. She is not dying because she is not eating very much, but she's not eating because she's coming soon to her dying time. This is the natural way of dying from dementia. I heard you say before that her comfort was really important. And to me, she looks peaceful. And you may say how you think she feels peaceful. She doesn't have a furrowed brow. Her tone is normal. She's not reaching out. She's not groaning. You can give some details of what you see that gives you confidence to say that she is indeed comfortable. And then, would it be okay if I'd ask again, would it be okay if we talked about how we can continue to focus on her comfort in the coming time, however long that might be? So you haven't had to actually provide any prognostic information at all. You've expressed some worry based on your perhaps previous conversations with the team, because you've had comfort care rounds and she's come up. But then most of the time, you're just asking questions and providing space to talk and providing little nuggets of information. And so I've included these other two boxes here with the tell and the ask, and you just keep moving along the ask, tell, ask with little nuggets of research-based, clinically supportive language. And now we're at Michelle, who's clinically frail. She's now in a deteriorating phase of her illness. And so this is one of the tools that we came up with, and I hope some of you have seen it, that with the long-term care quality improvement project. And it's a poster that sits in, is meant to be up in the facilities, and in our 4 test facilities, it was up there. And it really is a reminder to us to discuss the progress from increasing frailty to increased medical and functional decline, moving into the last weeks to active dying, and then into death and bereavement. And that there's actually a predictable path that most patients will follow. So for frail people admitted to long-term care, this is the last season of their lives, and phrasing you might use are, we are here to support and care for you to live well until the end of your life. They may still have long months. I think at 40 to 50%, they may have years, but they may also just have months. And then you need to be asking yourself, is this resident at high risk of dying in the next month? And if so, then we might want to lean in a little bit more to the goals of care conversations. And then there are signs that a resident's health is declining. Dying is possible at any time in the coming months. And the language you might use are, things are changing for you. This seems to be a good time for a family conference. And then moving to the last weeks, dependency and symptoms increase, death is now expected. Your mom is more frail now and coming, or your wife is more frail now and coming closer to the end of her life. And then in the act of dying, your mom has changed more and she is in her dying time. And so the poster was used for families that they might stop while they're waiting for their loved one and have a look at it and just absorb it. It's for staff to be reminded to be watching for these changes. And it also works as a communication tool where you can say, well, come, let's have a look and think where your mom or your dad or your sister is in this space towards her dying time. We had to do a lot of cultural work on making space for this and having it present so people would see it, but not in a place that some might be upset by it. But most found that this to be a very acceptable intervention. And this is another one that you can actually access on the Island Health website. And it's a conversation tool with a script and more sample statements. So you just go to the internet, go to palliative and end of life, and go to long-term care initiative, and you'll, or long-term care, palliative approach and long-term care, and you'll find it. So if a patient has been identified as moving towards their end of life, or there's a change, then you again go through the ask, tell, ask, and you'll see the same questions in the script. I wish things were different. I worry that time is getting shorter. I wonder if we could talk about how we provide care for your mom at this time. I can tell you how many articles have been written on the I wish, I worry, wonder statement. And it was a real game changer for me because it really allows alignment and seems to just make a real shift in the conversation, one that may have some conflict into it, into one that we're clearly all in the same side. So you should be able to access that and read through this. And you might even try saying some of these phrases out loud to each other on break, or maybe there's some space in your long-term care for an educational huddle where you might choose some of these phrases and practice them in your mouth coming out, because they feel really awkward at first. But over time, they will feel natural. There's some people feel, well, if I use these, it's not my words, and so it's not going to come out naturally, but that's because you need to practice them. And you do want to avoid the uncanny valley of it feeling robotic. But if you are sitting there in authentic concern for the patient and family, they will see that. They will absolutely see that. So now there was a question that came up about I'm often asked how long my mother has got to live. Should I call the other family members to come and say farewell? I explain that this is not an exact science, but when pressed, I will give them an idea and they are very appreciative. I have been wrong and I have been close. Whichever way it turns out to be, the family appreciates an educated guess. And I would challenge you, David, in saying they appreciate you engaging in the conversation and not so much the guess, but really the process of providing space to have that conversation. And my approach is to understand that it's always the elephant in the room. And so I do ask about their understanding first, and then ask about what information would be most helpful. And sometimes they come right out and ask about timing. And then I have a different approach depending on the rapport that I have with the patient and family. So I might say something. I usually give 3 types of prognosis. One is a functional prognosis, or disease trajectory prognosis. One is a uncertainty prognosis, and one is a time-based prognosis, and it will be adjusted depending on, as I said, the rapport I have with the patient and how tender I feel they are, and also how much information they have asked for. So I might say this is if they say, well, how much time does she have to live? And I'll say, well, this is a really, really important question because it helps us plan. So first of all, I thank them for asking the question. And I might say that sometimes families have a sense in themselves of how things are going. And I wonder, where are you at with that? And they might say, I don't know, you're the doctor. Or they might say, well, you know, based on how things have been changing so quickly, I expect it's not very long now. Or they might say, it's been going on for so long and I don't know how much longer I can take this. And so then that's your understanding and being in the same place question. And then I might respond with, although things can be uncertain with your mom's illness, we do know that over time with this illness, whatever it is that people tend to become weaker, to want to eat less and less, and to sleep more and more over time. And that's what I think I've heard from you about how things have been changing for your mom or your dad. And I expect that over the coming weeks or months, and I really are predicated on the rapidity of the change before. If things have been going really quickly, they're going to continue to go very quickly. If they've been going quite slowly, they're probably going to be continue to go quite slowly. And I think things may be as short as days, as short as weeks, as short as long months. So I never give 6 months or 3 months. It's always kind of a range. And I may say things like, this may be as well as they're going to feel. I worry this may be as well as they're going to feel. And around the family question is, should I call them in? And I say, you know, that is a tricky question. Can you tell me what feels important about family coming? Sometimes it's to have those important conversations and some quality time. And then for other people, it's important to be here right at the dying time. For you and your family, what feels most important? And then they'll say, well, he's at school, but I don't want to disrupt his school. And he was here last week. And I'll say, well, I suppose, how would it feel if grandpa dies and your son wasn't able to make it? how would that be? Oh, I actually got to have that good conversation and we were at the cabin last summer. And so then maybe we'll just see what unfolds for the next few. So it's really that back and forth, asking, telling, asking, trying to understand where the question is coming from and that person or family's perspective. And I hope, David, that answers your question. You could just give me a yes, or you could add in another little question into the chat if it did not answer your question. I did have another video, but I think maybe it's not really going to work because I'm not good enough at doing it. So getting better at conversations, how do you get better? And so the way you do it is what I have done in the past is I pick a skill and I work on it. If I'm going to practice, I wish I were, I wonder, I'm going to say to the resident who's with me today, the resident physician, say, okay, I'm going to work on this. You watch me, and then we'll talk about how it went. Or I'm going to make sure that I'm going to work on checking for understanding. Or I'm going to work on watching for metaphor in language and to explore what that metaphor means to them. You can access, there's tons of resources out there. And one of the ones that I really love, and I hope one day we can bring a long-term care version of this to Victoria, is called, perfect, David, is called The Vital Talk. And that was the video that I was going to show you. And they've got all these little snippets of providing prognosis, talking to a surrogate. And in that video, what I was wanting to show you, and I'm sure you guys all do this already, is that you bring the patient into the picture, is ask them, if your mom were here, and able to understand what's happening, what would she say? And they did it so beautifully. There's lots of courses out there. There's a LEAP long-term care that some of the residential care facilities will actually pay to send their staff to. And there is a great program run by Kath Murray called Life and Death Matters that's specifically for healthcare aides and other support staff, where it's a being with dying course, and much of that being with dying is conversation. And soon we'll have our Victoria Hospice palliative care intensive course, which will be a blended. This is a shameless promotion, but we've been working hard on it, and there's going to be lots of communication in it, where we'll have a blended online component and in-person component where we go through cases. And I hope sometime soon we'll have a long-term care style that will complement LEAP long-term care. You can join a community of practice. Pallium is this wonderful public health initiative providing education to people who provide end-of-life care. They are the creators of LEAP education. So LEAP stands for Learning Educational Approaches to Palliative Care. I think that's what it is. And take a risk and try some of these strategies. Talk to your colleagues about what you're doing, ask for advice, be observed, be brave. I think what Dr. Baker said, people thank you. People really thank you for it. And really it's a space to talk about what's happening, and that you've taken the time and you're providing presence. Goes a long way. You don't have to get it right. You absolutely don't have to get it right. And patients and families can be very forgiving. Yeah. Okay, we're getting to this is so cool. So and I can see this being used by rec therapists and volunteers, all kinds of people. So this is the Go Wish game, which Pallium has actually come up with its own game. So we have all of these complicated things like the ACP workbook that I showed at the beginning, that may be a little bit too complicated for some patients, but this is actually a card game where people, and I'm hoping to bring this to the hospice, where people will have cards. And there's actually a beautiful study where they take a small subset of the Go Wish game about cleanliness and privacy and other elements of day-to-day living, and they can kind of order them in the way in which feels most important to them. And so you can, and it acts as a conversation starter, you know, they might come up, this is important to me to maintain my dignity. And then you might ask, can you say more about what dignity means for you? And to have human touch, what feels comfortable for you? Oh, I love having my feet massaged or whatever. To have close friends near, can you tell me about who those people are and tell me a story about them, or tell me about how you and your husband or your partner met. And so I see a lot of potential for this Go Wish game, and there's actually been a flurry of about 5 studies in the last 2 years using similar types of games in which to get at goals of care. Victoria Hospice has their own game, but it's much for upstream, for serious illness, as opposed to those people in the 40% and below. So I was going to ask for a little bit of, just want to stop there and see if anyone has any questions or comments, tricks that they want to share, resources that they want to share. And maybe we'll start with that, and then we'll move on to the second part where we talk about sharing conversation. So I'll just wait for a few minutes to see what comes up in the chat. Are people still here? I hope people are still here. I'll still hear, good. Any particular questions about strategies? Okay, so please tell me in the chat how your team, when something's come up, you share information about patient goals, values, and treatment. Are these hallway conversations? Is there a place to document it particularly? Does someone in particular hold that information? How does this become a team understanding? Huddles in the morning, excellent. We have plan of care meetings where this can come up, and it's usually charted. And is it charted where all people have access and can find it? I find our goals of care conversations used to be embedded in people's beautiful notes, but I could never find them. Point, click care, progress notes. Unfortunately, embedded in the chart notes. Yes, that's pretty common. Each shift change in the communication section of PCC, patient care, something, chart, patient care chart. Yes, thank you, Jacqueline. Power chart, ACP, Power Farm. Yay. Point, click care. Okay. Care conferences are well documented, yeah. And so, so for Patrick, so he's been to the hospital and now he's returned on home oxygen. And so this was another tool that we developed for a palliative approach to care, where what was happening was that people were changing, and people might have had a sense that they were changing, but there wasn't a systematized way of identifying people who might benefit from another goals of care conversation. And so, so what we did was we sat with the residential care staff and we asked them what they noticed when people were moving closer to the dying time, and also used the supportive and palliative care indicators tool that we use. You may recognize it, some of you, from the Plan P. But really we felt it had to be adjusted by the people who were actually working with the patients in the long-term care home. So if the dietitian had noticed there was a weight loss of greater than 10% in 6 months, If the functional decline was just progressing, they were in that deteriorating phase of the illness. If they were actually asking for comfort measures or stopping treatment, I don't want to take all these pills anymore. If there were unplanned transfers to the emergency department or hospital admissions, and hopefully that's becoming less and less frequent. Extreme frailty, where there's persistent pressure, ulcers, infections, delirium, swallowing difficulties, falls. More advanced dementia, where they're well into the deep into the fast stages, unable to dress, walk, or eat, incontinence, unable to communicate, swallowing difficulties, recurrent urinary tract infections, aspiration pneumonia. A new cancer diagnosis or progressive cancer, breathlessness at rest or chest pain at rest, and advanced illness of any cause with progressive functional decline. And so the patient is identified or not identified at this time, and then this is what produces a cascade of events, including comfort discussion at comfort care rounds. So there's patient care rounds, but then what's instituted. This is a beautiful picture of Kelly Stajahar and Katie Leahy, who are both, Kelly is a wonderful palliative care researcher, and Katie works with our palliative and outreach team with the homeless population. But it's actually specifically there to provide a space to debrief on, discuss patients who've been identified, what's been noticed, some of the questions that you came up at the very beginning. What do we know about them as a person, their goals and values? Do we need to revisit these? Who on the team is best placed to talk with the patient or reach out to the family? And also what I didn't include here, which I should have, it's a space to talk with each other as a team on and debriefing. Maybe a patient has died, and this provides a space to talk about that. What about what gives them meaning or spirit or strength of the spirit, and how in their new place can we continue to support that so that they can live as well as possible through this dying part of their illness. So the comfort care rounds, according to the project that was done in Ontario and in our BC grown one, was really seminal. So what we did was I think it was, in some places it was every 4, in other places it was every 6 slot for care conferences. There then became these comfort care rounds. And it was highly, when we evaluated, it was very highly valued by the staff. But it was an opportunity also for education, and where we could, and sometimes the palliative care doc was there, but more often another essential element of the palliative approach was to have someone who was a champion in there, who was particularly skilled or interested in goals of care conversation, and supporting the team to do pain and other symptom assessments. Comfort rounds are so, Teresa, is that the Teresa from our study? Say yes or no, Teresa. I think so. Yes. So comfort care rounds are valuable, and that is, and not only did we find that in our study. Thank you, Teresa. So nice to see your name there, but also in the work that's been done in Ontario and across in Europe as well. And like I said in the opening, I really hope to see these tools, the comfort care rounds, the identification tool, a letter that's coming in a minute, our ACP conversation tool, spread somehow into the long-term care facilities here. Because unbeknownst to us, we were actually at the leading edge of the palliative of long-term care change in practice, and the difference was that we just didn't have the ability for the knowledge translation and the spread. But that will be, hopefully somebody with some money will come up with it, and we'll begin to spread it. So I'm down to just the last few slides. Excuse me. So the other part of our toolkit was this letter to the physician, and we really, palliative care and long-term care is a team sport. And I know that things have really improved with, I can't remember the name of the group of the residential care initiative where people work in groups. But this was a real problem in the facilities where we were, where the physicians seemed to be less often in the loop of what was happening with the patients. And so this was an attempt to bring the physician and say, well, this is what we've identified. And could you please do a reassessment? And sometimes that assessment was the family would go and visit the patient in, or the family would go and visit the physician in their office, or the physician would come in and arrange a family meeting, or a care conference would be booked, at which time a modified serious illness conversation would happen and the goals of care would be revisited. And so, and here's my note, physicians can then reassess and engage in further discussions, perhaps about prognosis, because really that is the realm of the physician. There are some things that non-physician colleagues and nursing staff can do, and there's actually training for non-physicians in the art of prognosis telling. Oh dear. Excuse me. And so really, now I'm at my last slide with a little bit of time left over if you have questions, is really thinking about next week and how you might take some of what we've gone over here, which may seem like it's soft, right? Like these are soft skills. These are not soft skills. There is article after article showing how effective communication improves authentic dying, improves patient and caregiver satisfaction, improves the team experience of care. So as Cecily Saunders says, is that palliative care is difficult medicine with a kind face. So what I would ask you to do, if you could, we've talked about resources that you can use, the Ask Tell Ask long-term care resource to share with your colleagues. You can take it and either email it or print it off and post it somewhere. Talk about it with your colleagues. Give it a try. Try the asking, the telling, and the asking. Try, tell me more. Try, I wish, I worry, I wonder. You can go online, and also on the palliative and end of life site on the internet is you can access the disease trajectory handout so that you can have a conversation with your patient or family member, talk to them about what might be expected based on the type of information they've requested, and then share the disease trajectory handouts with them or a link to them. You can Google LEAP long-term care to see if there's a course coming near you, and maybe ask your supervisors to see if there's funding to send you. But totally free. There are some Pallium resources on conversations on the internet, and free Echo community of practice for long-term care. Some of it will talk about pain management. Some of it will talk about being with dying. Some of it will talk about how do we talk to our patients and families. And then if you can, please talk to your team about what might work in your facility to identify patients who might benefit. How do we document the conversations if it's hard to find what's most important to the patient? Potentially institute comfort care rounds. And the complete palliative approach long-term care toolkit is on the Island Health Palliative and End of Life Intranet. The Palliative and End of Life program is super keen to see this spread, and Victoria Hospice is happy to be an added layer of support to support things like comfort care rounds and education around communication and end of life. So that is my presentation, and I'm really, really happy to take questions if anybody has any. Could we go to gallery maybe, and people undo their cameras so we can see each other and chat for a little bit?
Unfortunately, we don't have the option for people to turn on their cameras with the presentation.
Oh, yeah, no problem.
Yeah.
Oh, and then here's a few resources here at the very end. With that interdisciplinary staff perceptions, the ACP workbook, the card game assessments, yes. If I don't get questions, then I think people haven't understood. As a chaplain, palliative care is also care, absolutely. Family's relationship continues even after the resident's death. When I was asked to do memorial, absolutely. And even if patients have not died on Victoria Hospice, we have there's probably you guys have the mygrief.ca that's out of the Canadian Virtual Hospice. That's another wonderful website for educational resources. But in particular, they have a section called mygrief.ca. And there's some wonderful modules there. And Victoria Hospice has free bereavement counseling for anybody experiencing grief. That grief could have happened 50 years ago. It might be very fresh. And really, that's probably the most active part of our program. And so I would encourage you to also refer your patients, if they don't have any other services, to Victoria Hospice for that. Oh, no, I don't. You guys will have access to the slides, so I don't think that I need to go back to screen sharing. I know I love the card game too. I can't get any traction on it here, so I think I'm just going to buy the card game with my own money and just hand it out. The challenge sometimes is when the resident status improves. After an almost decline, dying conditions, they perk up. And when they decline again, the family and the staff too become unsure what to expect next. Absolutely. And that is the uncertainty. And we got into trouble with this a number of years back when we would institute these end of life order sets. I can't remember what they called it, the liver pool care pathway, where when there was a decline like that, even in long-term care, or in hospice, they would initiate these fairly aggressive end of life orders. So we took someone who had the potential to improve, and through these medications, there was quite a bit of sedation. And so this was worldwide, this is what was happening. And so we needed to move away from the end of life order sets. But yes, and that's why those trajectory graphs are so very helpful to show that things can go up and down, and it can happen in frailty, and it can happen in dementia as well. One of my favorite phrases is "we're in a new place now." And and then you say, so it seems that things have changed, and he's feeling better. Tell me now that he seems to have stabilized somewhat. What do you think is going on? What's most important now? So it's to continue, even with that, it's the ask, tell, ask, the acknowledgement of the uncertainty. I think even when things go up and down, I bet you that they probably don't get perked back up to the level that they were previously. And so you can just go back to those trajectory slides or handouts and discuss that sometimes we have good days, sometimes we have not so good days, but overall the general trajectory is one of increasing functional dependence as someone moves towards their dying time. I think changing the term used from end of life to palliative order, because with the ups and downs, when they bounce back, the family sometimes think that they are no longer end of life. It is still a decline and will decline again at some time. It is, oh, nicely done, Sherry. It is the stage or season of the end of their life. Yeah. We really suffer from definition fatigue. Back in, it was all hospice care, which is the modern hospice movement by Dr. Cecily Sanders. And so everyone was talking hospice, and then Dr. Balfour Mount in Montreal coined the word palliative. to really see that this could be moved upstream, but then palliative became associated with end of life. And then it became, oh, supportive care, like, and so, but really what's happening to the patients when they come to long-term care, they are indeed in the last season of their life. Most people will die within long months. Some people live very much longer, but most people will die sometime in the next year or two. But I love that season. And in fact, sometimes that's what I do with prognosis. I didn't mention that, is I'll say, you know, the daffodils are coming up. And I think that you'll probably see the roses in your garden, but I'm not sure you'll see those leaves changing. Or I worry that Christmas might be a bit optimistic or something like that. So using season language in my prognostication is very common. One thing I struggle with, oh yeah, you know, the cultural piece, I struggled whether to put cultural and equity in here because those are really important issues, but it just felt so big. The lack of cultural food served in long-term care, absolutely, especially older adults crave comfort food, which is often what they grew up with. Having a rice cooker on all the time for patients and families is not difficult. Consultant managers, dietitians, is still no change. And yes, I feel like palliative care or end-of-life care more than anywhere else should be an area of negotiation and nuance and flexibility. It's hard enough for older adults that speak little or no English in long-term care and not to have the food they want is indeed heartbreaking. I would agree. And here in hospice, we do have the hospital food for whatever that it is, but we also encourage families to bring in their own foods. And I can see that, you know, maybe a compassionate communities project would be a nice one with a community organization where they might be able to bring food into long-term care for those patients. That might be a really neat compassionate communities project one day. But then again, you know, as people do come to the end of their life, they do become less hungry and they want to eat less and less. So it's more of the more upstream, because as they move from 30% to 20%, they're really just having very small sips of fluid. And food has such important meaning. However, those are often difficult conversations too. But I think we're just about out of time.
Thank you so much, Dr. Jones, for such a wonderful presentation. We really appreciate you being here to talk to us today.
Oh, you're very welcome. I learned lots in the preparation of it too. All right, guys, hopefully we'll see you in the long-term care facilities one time.
Thanks, everyone. Have a wonderful evening.